This presentation is about understanding the neuroanatomy and pathophysiology of dystonia for developing best treatment practices. Dystonia is a movement disorder characterized by continuous or intermittent involuntary muscle contractions that can result in repetitive twisting movements, abnormal postures, or both. The core issue involves overcontraction of the primary muscles used for a movement, along with overflow contraction of adjacent muscles that may antagonize these primary muscles. Almost any region of the body can be affected, alone or in various combinations with other regions. Dystonia is still not completely understood, and new and revolutionary discoveries and treatments are constantly being made in an effort to battle this debilitating disease. By better understanding the neuroanatomy and pathophysiology of this disease, we can better delineate proper classification practices to aid in establishing an accurate diagnosis, as well as identify effective treatment options that reflect best practices and the latest research in the field. The neuroanatomy of dystonia is largely misunderstood, and the multitude of working components that result in its manifestation are still being studied, with new discoveries being made every day. While it is widely accepted that dystonia stems from abnormalities in the basal ganglia, many researchers have come to recognize that other regions of the brain are most likely involved. This is supported by neurophysiological evidence that suggests defects in neural inhibitory processes, sensory-motor integration, and maladaptive plasticity. This is also evident by the fact that only certain types of dystonia can be successfully treated by targeting the basal ganglia. Even when structural defects in the basal ganglia can be linked with dystonia, the emergence of symptoms can be delayed by weeks or years following the lesion, which implies that loss of function from the lesion itself might not be the direct cause of dystonia. Surgical benefits targeting the pallidum of the basal ganglia, such as with deep brain stimulation, are also typically delayed by several weeks or months, implying that success may depend on secondary neural responses to the procedure. These delayed effects suggest that a process of progressive plasticity and neural reorganization accompanies the long-term effects. This provides evidence that other unrecognized influences are most likely involved. Understanding which region of the brain are responsible for this condition is paramount to improving research methods so that more effective treatment options can be developed. Evidence suggests that the cerebellum may also be involved in the development of dystonia, because unlike the basal ganglia, which only receives sensory information indirectly, the cerebellum receives sensory input directly from the spinal cord through the inferior cerebellar peduncles. This part of the brain processes proprioceptive information, alters somatosensory thresholds in the cortex, and is involved in temporal and spatial discrimination. There have been voxel-based morphometric studies that have found gray matter in the cerebellum of individuals with focal dystonias. There was also a finding of reducing eye blink classical conditioning in focal dystonias, which provides further evidence of functional cerebellar involvement. There have been extensive studies of modern imaging that reveal abnormalities may also occur in the cerebral cortex, cerebellum, thalamus, midbrain, and brainstem. In a study conducted by Abeso and Jimenez Roldan, they discovered that brainstem lesions were more common than basal ganglia lesions, leading them to suggest that the location of lesions may vary according to the type of dystonia. This hypothesis was further validated in a study conducted by Ledoux and Brady that found among 25 cases that were studied that 11 had lesions in the brainstem or cerebellum, 6 had lesions in the basal ganglia, and 6 had lesions in the spinal cord. There have been many structural imaging studies that link limb dystonias with focal lesion in the thalamus, with some occurring in subnuclei receiving information from the basal ganglia and others receiving information from the cerebellum. The limitation of these studies is that it can be difficult to distinguish the cause from effect, because dysfunction of one region of the brain responsible for dystonia may lead to downstream effects in other regions. New research suggests that healthy nodes of the brain at a distance from the primary deficit may react and rearrange themselves in response to damage. This plastic reorganization might be either adaptive, compensatory, or maladaptive, which possibly worsening the deficit. Based on all the evidence presented, it is reasonable to believe that dystonia is in fact a network disorder with many interconnected parts that may be affected, rather than being strictly confined to the basal ganglia, as was previously thought. On this slide, you can see the neural pathways. In panel A, it shows the most commonly assumed model that involves defects in the subcortical pathways of the basal ganglia, and the cerebellum being transmitted through the cerebral cortex, causing the expression of dystonia. In panel B, it shows an alternative schematic whereby dystonia can be expressed directly through subcortical pathways like the interstitial nucleus of Cajal. Classification of types of dystonia. Dystonia is a highly variable, often misunderstood disease, which can make it difficult to differentiate between various types to determine best treatment options. There are three major factors to consider when distinguishing a diagnosis of dystonia: etiology, or the causative origin of the disease, the age of onset, and the affected area of the body. By considering these categories, ideally an accurate diagnosis can be made that will assist in determining the most effective treatment options for a patient's unique condition. Etiology. One important consideration that must be made when classifying types of dystonia is the etiology of the disease. By understanding the origin of a specific type of dystonia, medical professionals can prescribe more effective treatments. In inherited dystonia, there is an established genetic link that can be passed down through DNA. With acquired dystonia, it's not inherited, but can be traced to a specific cause, such as a brain injury, infection, substance abuse, exposure to toxic substances, neoplasms, vascular causes, or various psychological or functional issues. With idiopathic dystonia, there is no known origin, but new discoveries and advances in genetic technology are being made every day to help reclassify these types as their origins are determined. Age of onset. The onset of dystonia can occur at any stage of life, though many characteristics and types are more common among certain age groups. With childhood onset, dystonias that first express symptoms often begin in the limbs and may progress to affect other body regions. These types tend to express symptoms after periods of exertion and may fluctuate through the course of the day. Adolescent onset occurs when symptoms first arise between the ages of 13 and 20. With adult onset, which occurs at the age of 21 or older, dystonias first are usually located in one or adjacent body regions, and most often involve the neck and/or facial muscles. Body distribution. Classifying dystonia by what region of the body or regions of the body are affected is medically important in determining a diagnosis and treatment options. For example, focal and segmental dystonias are commonly treated using botulinum neurotoxins, while generalized dystonia is often treated with medication or surgery. The main body regions affected by dystonia are the upper or lower cranial region, the cervical region, the larynx, the trunk, and the upper and lower limbs. These regions may be involved individually or in different combinations and may change or progress over time to other parts of the body. Dystonia is generally categorized in 5 different patterns of bodily distribution. There's focal, which is when only one region of the body is affected. Some common types of focal dystonias are cervical dystonia. Let's go on to the next slide. Cervical dystonia, which affects the neck muscles. Blepharospasm, which causes forcible contraction of the eye muscles that control blinking. Oromandibular, which controls the jaw, lips, and tongue. And laryngeal, which involves the vocal cord muscles and affects speech. And then there's writer's cramp, which affects the hand muscles. With segmental dystonia, 2 or more adjoining body regions are affected. Some examples of segmental forms of dystonia are cranial dystonia, cervical brachial, bibrachial dystonia, and spasmodic dystonia. With multifocal dystonia, this occurs when 2 or more non-adjacent body regions are affected. Generalized dystonia involves the trunk and 2 or more other body regions and is characterized by twisting of the limbs and torso. Hemidystonia affects regions on only one side of the body, often results from acquired brain lesions in the contralateral hemisphere. And here is an image of some of the common inherited forms of dystonia. And you can see examples of the gene, the affected chromosome, their clinical features, and the mode of inheritance. So some common treatments. Treatment for dystonia is not a one-size-fits-all. There are various treatments available to those suffering from dystonia, and their effectiveness can often be projected based on the classification criteria highlighted above, namely the region of the body that is being affected by the disease. Some of the most common treatments available are botulinum toxin injections, deep brain stimulation, and various medications and therapies. With botulinum toxin, this treatment has proven to be most effective for certain types of focal dystonias. It works by inhibiting the release of acetylcholine into the neuromuscular junction, which relaxes the abnormally contracting muscles. Injection of botulinum toxin directly into the affected muscle can prevent muscle contraction and alleviate symptoms of dystonia. The effects of this treatment are generally observed a few days after the injection and usually last a few months before the injection will need to be repeated. One drawback of this treatment is that certain patients can develop neutralizing antibodies that can make it less effective or ineffective after subsequent treatments. Deep brain stimulation has proven to be an effective treatment for sufferers of certain types of dystonia, such as generalized and focal dystonias. Those who suffer from this type of dystonia can have an excess of LTP-like plasticity, which can lead to the formation of inappropriate connections between inputs and outputs of the motor system. This can be difficult to correct because of the connections accumulate over time. It can cause an excess of involuntary movement that becomes increasingly difficult to reverse. And you can see over on the side all of the components of the deep brain stimulator. And I'm running out of time, so I'm gonna have to speed this up. Okay, here's some medications and therapies. Let's see. Gotta summarize here. There's anticholinergic agents, which block the effects of excitatory neurotransmitter. It's the neurotransmitter acetylcholine, which triggers muscle contractions. Then there's the GABAergic agents, which regulate the inhibitory neurotransmitter, GABA, or gamma aminobutyric acid, which contributes to motor control and other cortical functions. And then there's dopaminergic agents, which affect the neurotransmitter dopamine, which control movement and posture. Let's see. Dystonia is a disease that is still vastly misunderstood, and significant treatment options are limited. By gaining a better understanding of the neuroanatomy and pathophysiology of this devastating disease, we can continue to modify and improve methods of classification and diagnosis so that new, more effective treatment options can be discovered to help those that suffer from the disorder to lead more independent and fulfilling lives. With further education and research, this can be accomplished, and we may see a dramatic increase in the mobility and capabilities of those that suffer from dystonia in the years to come.